You know, when we talk about heart disease, it's almost always in the past tense. We're talking about stents, bypass, what happens after the disaster.
Right, the aftermath.
But the research we're looking at today suggests we can almost travel back in time.
In a way, yeah.
Yeah.
We're talking about the coronary CT angiogram, or CCTA. And the sources, like the VertiCT trial, they show this isn't just taking a picture, it's about predicting the future of your heart with incredible accuracy.
Okay, that's the big promise. And I want to start with one number from that VertiCT trial because it just floored me. 90.9%, the negative predictive value.
Right. And so just to break that down, what that really means is if this test says you're clear, you are very, very likely clear.
Which is pretty rare in medicine, isn't it? I mean, usually a test is there to tell you what you have.
Exactly. This one is powerful because it tells you what you don't have. If CCTA rules out obstructive disease, we're about 91% sure that person is safe from that specific problem.
So it saves them from a more invasive procedure.
It saves thousands of people from going to the cath lab for a diagnostic look-see that they just didn't need.
It's a filter.
It is. The sensitivity is even higher, 96.5%. So it's great at catching disease. But, and there's always a but.
Oh.
The notes all emphasize that getting that kind of accuracy is not just point and shoot. It's more like a high-stakes film production.
Yeah, I was looking at the patient prep section. It's intense. It says motion is the enemy.
It's more than that. The heart is the most dynamic engine in the body. We need sub-millimeter precision on a moving target. If the patient even breathes at the wrong time, you get what's called a step artifact.
And that looks like a blockage.
It looks exactly like a blockage.
Yeah.
But it's just a blur.
So you have to nail the setup, which brings us to this cocktail. I'm looking at this and it seems a bit aggressive. You're giving patients beta blockers to essentially crash their heart rate.
Well, crash is a strong word,
Yeah.
but we absolutely have to slow it down. The magic number in all the literature is under 60 beats per minute.
Under 60. That's like deep sleep level for most people. Why so low?
It's about physics. The coronary arteries, the pipes we're trying to see, they fill with blood in between beats when the heart is relaxed.
That's called diastole.
Exactly, diastole. The slower the heart rate, the longer the diastole.
So you're just trying to make that window of relaxation as wide as possible for the picture.
Precisely. If your heart's racing at 90 because you're anxious, that window is just too short. You get motion blur.
Okay, so that's the metoprolol. But then there's part 2 of the cocktail, nitroglycerin. I mean, that's the stuff you see in movies when someone's having a heart attack.
Right, they put it under their tongue.
So why are we giving it to a patient who feels totally fine?
This is the part that always surprises people. In the movies, it's for pain. Here, in the scanner, we're using it for its mechanical effect, vasodilation.
You're blowing up the arteries like balloons.
We have to. Some of the branches we need to see are tiny. The nitro forces them open, so the contrast dye can get into every single nook and cranny. It's like turning on your high beams.
Got it. Okay, so the patient is prepped, heart slow, arteries are wide. But before the big scan with the dye, there's this pre-scan, the calcium score.
The Agatston score, yeah. This is a quick scan with no contrast. We're literally just looking for bright white specks.
Because calcium shows up on an X-ray.
Just like bone. If you have plaque that's hardened, that's calcified, it lights up.
And the logic seems simple. More calcium, more plaque, more danger. 0 is good, 400 is bad.
Generally, yes. It's a fantastic risk predictor. But, and this is a big one, there's a huge paradox here that really confuses patients.
I think I know where you're going, the statin paradox.
Exactly. You put a patient on a high-dose statin, a cholesterol drug, and over time, their calcium score might actually go up.
Which sounds awful. You're taking the medicine and the problem is getting worse.
The score gets worse, but the risk goes down.
How does that work?
Statins work by sucking the liquidy fatty core out of the plaque. They shrink the dangerous mushy part.
And the mushy part is the bad part.
That's the killer. That soft plaque is unstable. It's like a pimple on the inside of your artery. If it pops, you get a clot, and that's your heart attack. When the statin takes the fat out, what's left behind is the scar tissue, the calcium.
So it hardens into concrete.
It stabilizes. That's the key word. A rising calcium score on a statin can actually be a sign the drug is working. It's turning a soft time bomb into a stable rock.
That is a critical distinction. Okay, so we've checked for calcium. Now the main event. Inject the dye, hold your breath. And the notes mention 2 ways to do this: prospective and retrospective gating. This felt like a sniper versus a videographer.
That's a perfect analogy. Prospective is the sniper. The machine watches the ECG, waits for that relaxed diastole phase.
And then snap. One shot.
One shot. Minimal radiation. But you need a rock-steady heartbeat. If the heart flutters, you miss.
And retrospective.
That's the videographer.
Yeah.
The X-ray beam stays on the whole time, recording the entire cycle. Then we go back later and pick the best, clearest frames.
Sounds safer, but I'm guessing it's more radiation.
It is a higher dose, yeah. But for a patient with an arrhythmia and a regular beat, it's really the only way to guarantee you get the shot.
It's incredible. And sometimes you're not even just looking for coronary disease. There's this triple rule out.
This is huge for the ER. A patient comes in with chest pain. It could be the heart, sure, but it could also be an aortic dissection, a tear in the aorta, or a pulmonary embolism, a clot in the lung.
3 different killers.
3 different killers,
Yeah.
and traditionally 3 different scans. With the triple rule out, we time the contrast just right, so the aorta, the pulmonary arteries, and the coronaries all light up at once.
1 scan, 3 answers.
Huge for efficiency.
Okay, let's move to interpretation. The scan is done. The radiologist is looking at this 3D map, and the mantra is, don't just look at the blockage.
Exactly. You have to check the plumbing layout first. Origin, course, and termination.
Because sometimes the layout itself is the problem. Let's talk about these malignant anomalies, specifically the interarterial course. The notes say this is a cause of sudden death in young athletes.
It's tragic, and it's a silent mechanical flaw. Normally, the coronary artery runs on the outside of things, but in this anomaly, it takes a wrong turn and runs between the aorta and the pulmonary artery.
Between the 2 biggest pipes in the chest?
Right. Now, when you're resting, that's fine. There's plenty of room. But imagine you sprint for a bus.
Heart pumps harder. Blood pressure goes up.
And the aorta and pulmonary artery expand. They swell up. The space between them shrinks.
And the coronary artery gets crushed.
It gets squeezed like a vice grip. And this happens at the exact moment you need the most blood flow during maximum exertion. That's why it often presents as a collapse during sports.
Wow. It's a scissor mechanism you'd never find on a normal test.
Not until it's too late sometimes.
Okay, let's move down the checklist to the course, the path the artery takes. Myocardial bridging. This one fascinated me. The heart muscle grows over the artery.
Yeah, instead of the artery sitting on top of the heart muscle, it actually tunnels through it for a short segment.
So it's being squeezed with every heartbeat.
It is. But here's the really weird part. The plaque, the atherosclerosis, it almost always forms in this segment just before the tunnel.
Why before? I would have thought the part getting squeezed would be the problem area.
You'd think so, but that squeezing action actually protects the vessel inside the tunnel. It keeps it clean. The problem is right before the tunnel, where the blood flow hits that constriction and gets all turbulent. That turbulence injures the vessel wall, and that's where plaque loves to form.
So if you see a blockage right before a clean segment, you should look for a bridge.
You have to. It completely changes the treatment plan. You can't just stick a stent in there. The muscle could crush it.
And what about termination, where the vessel ends?
The big one there is a fistula. That's when a coronary artery connects to something it shouldn't, like directly into a heart chamber or the pulmonary artery.
It creates a shortcut.
And in circulation, shortcuts are bad. Blood is lazy. It follows the path of least resistance.
So it bypasses the heart muscle it's supposed to be feeding.
Exactly. We call it steal syndrome.
Yeah.
The fistula steals the blood flow away from the tissue that desperately needs it.
The variation is just incredible, but the sources make a huge point. The radiologist can't just have blinders on for the heart.
Don't wear blinders. It's the golden rule. We're scanning the whole chest. We see the lungs, the bones.
The guide specifically mentions looking for extra cardiac findings.
For good reason. A patient comes in with chest pain. Everyone's thinking heart attack. But the scan shows a rib fracture they never knew they had.
Or pneumonia.
Or pneumonia or a lung cancer nodule. We find them all the time.
There was even a note about seeing asymmetrical density due to filler injections in breast tissue.
Right. It's a reminder the scan sees everything. But critically, radiologists find incidental breast cancers on these scans. You're looking for one killer, and you might find another one in its earliest stages.
It's truly a whole patient scan. Okay, so we've done the prep, the scan, checked the anatomy, looked at the lungs. Now,
The report.
the
Yeah.
paperwork.
The paperwork.
Okay.
This is where it all comes together. We use a standardized system called CAD-RADS 2.0.
CAD-RADS. It sounds like a droid, but it's the coronary artery disease reporting and data system. Before this, reports were all over the place.
Oh, a total mess. One radiologist would write mild disease. Another would say non-significant plaque. What does that even mean? CAD-RADS turns it into a simple score from 0 to 5.
So break down that scale for us.
Garessa is completely clean pipes. 1 and 2 are mild non-obstructive plaque. 3 is moderate stenosis, that's 50 to 69% blocked. That's the gray zone where you might need more testing.
And the higher numbers?
4 is severe, over 70%, and 5 is a total occlusion, 100%. That pipe is shut.
But it's not just the number. The real game changer seems to be the modifiers. These letters you add on, specifically HRP.
HRP, high-risk plaque. This is the revolution. It connects right back to that statin paradox we talked about.
Because for decades, the thinking was just how blocked is the pipe? Size was everything.
Right. Is it 70% blocked?
No.
Then we need to open it. But the data shows most heart attacks actually happen in arteries that are only, say, 30 or 40% blocked.
Because of that vulnerable plaque, the pimple.
Exactly. The HRP modifier is the radiologist telling the cardiologist, hey, this pipe is wide open, blood flow is great, but the wall of that pipe is made of dynamite. We see signs like a napkin ring appearance or spotty calcium that tell us a plaque is inflamed and ready to rupture.
So a patient could have a low score like a CAD-RADS 2, but with an HRP modifier.
Yes, and that patient is arguably in more danger than someone with a stable, rock-hard, calcified 80% blockage. It completely flips the script.
It changes the question from how clogged are you to how inflamed are you?
That's it exactly. And there's one last piece, plaque burden, P1 to P4.
And what's that measuring?
CAD-RADS gives you the single worst spot. Plaque burden gives you the total amount of plaque and all the arteries combined. You could have one really bad spot but be otherwise clean, or you could have mild disease absolutely everywhere.
And that patient with disease everywhere might be at a higher long-term risk.
That's the thinking. So a report might say CAD-RADS 4HRPP3. That one line tells a cardiologist a whole story in seconds.
That's the goal, right? Clear communication.
It saves lives.
So we've gone from the beta blocker cocktail all the way to this incredibly detailed score. It really has turned a guessing game into a precise checklist.
It has. We used to rely on stress tests, which are indirect. We inferred a problem. Now we just look. We open the hood and see the engine.
And we can do it before the engine breaks down.
That's the whole point. We're moving away from waiting for the heart attack. We identify the dangerous anatomy, we see the dangerous plaque, and we can intervene before it's a catastrophe.
Which brings us to our final thought. We've talked about the vulnerable plaque, but I want to leave everyone with a bigger idea. The vulnerable patient.
It's a huge shift. Cardiology used to be a plumbing business. Fix the clog.
Right.
But now with tools like this, the question isn't just, can we see the blockage?
It's what kind of blockage is it?
Exactly. So the provocative question is this. What do we do when we find this high-risk plaque, this HRP, in a 45-year-old marathon runner who feels perfectly fine?
Do you treat them like a heart attack survivor today?
You're treating the biology, not the symptom. It opens a whole Pandora's box of medical ethics and questions, but it is without a doubt the future. We are moving from reactive plumbing to proactive biology.
And CCTA is the lens that's letting us see it.
A lens right into the future of our own hearts.
Fascinating stuff. That's a wrap for this deep dive. Thanks for walking us through all that.
My pleasure. Keep your heart rate down, everyone.
See you next time.